Hello, everyone. Welcome to this episode of Compassion and Courage, Conversations in Healthcare. I am Marcus Engel. I am your host, and this is the podcast where I teach compassionate communication, inspire resilience, and provide perspective. Thank you to everyone who has subscribed and shared and rated and reviewed the podcast over the last couple of months. We really appreciate you pumping it out to the world. Today, I am super excited because I get to introduce Dr. Tara, correct? Correct. So see, here's the problem, Dr. Nichols, is whenever it's reading it back to me on my computer and my screen reading, oftentimes it mispronounces names. So I apologize for messing that up. But thank you and welcome to the podcast.
Well,
I am so excited to share you and your knowledge with all the listeners. So you are an advanced practice nurse, and your current position is...
Well, currently I work for Waldorf University in Forest City, Iowa, as the program director for the RN to BSN program. But I'm also an advanced practice nurse, and my specialty is pain management. And I'm in the process of starting my own private practice.
You wear a lot of hats. You wear a lot of hats.
I do.
And I'm always excited to talk to any nurse, and I'd love to. I want to get all into your background. I hope that's okay with you. I want to get all into your background and your research, and really understand the reason why this has been your profession and your calling of choice. Can you take us back to, I guess, kind of the early life of yourself, and kind of take us through your journey?
Well, I started off as a critical care nurse, working with very sick patients, and was a single parent, and obviously needed to work, to pay the bills. And one day I got an opportunity to work on a pain service, and really loved the independent practice of being able to make decisions to improve patient outcomes. And inevitably, I would always get a call that somebody had gone to surgery, and before they would go to surgery, they would get medication in their IV. The nurse would come and administer it, and then after they would come back from surgery, they would be on a machine where they would push a button called a PCA, most people, patient control analgesia. And that works for a lot of people. But some people, they would say, this medicine isn't working, it's not doing anything for me. And the nurses would say, they want to see the pain nurse. And I would go down and I would say, well, it's the same medication. And the patient would be like, yeah, but it's not working. And so one night I sat next to a patient and I gave her some extra medication and got her comfortable. And I said, so tell me why this medicine is different. And she says, well, the nurse comes in and she fixes my bedclothes and we talk about my kids and she tells me I'm going to be okay. And she gives me the medicine. And that medicine works so much better. But this medicine, I'm pushing the button, it's not working. I don't want this. And I'm like, okay. So what's missing? What's missing is that touch, that human connection. And she's telling us in her own way. And as you talk about this human connection, is human communication, and we're missing it. And so I would go out and I would DC this machine and I would put her back on nurse administered pain medication. And the nurses would get so mad and they'd be like, what are you doing? What are you doing? And I said, she needs you. Part of her treatment, part of her medication is your physical presence. And without that, this same medication is not working. It's not working. And so that really became my journey to pain management and understanding the clinician-patient relationship and this communication that is so important that sometimes we minimize this connection. And that's kind of where
the social and emotional connection with a patient actually was more beneficial than medicine alone.
I say if not more, it is at least just as. And I do a talk where I talk about the therapeutic use of self as an intervention for pain management, because I can walk in a room and I can say, Marcus, here's your Tylenol, or here's your acetaminophen. And I can walk in the room and I can say, Marcus, how are you doing today? And I can touch your hand, and you could tell me about your wife, or you could tell me about your pet, and then I could give you your Tylenol. Now, in both situations, you still got your medication, and it's still going to work at the cellular level the way the medication works. But the difference is the connection that you make with me that's caring, that's comforting. And so I become the embodiment of comfort to the point that I begin to elicit comfort when you see me before I even say anything. Because, oh, here comes Tara, my nurse. She's so comforting. Because you already know when I walk in the room that I'm going to be comforting to you. And so my presence, my being is just as important as the medication. It's part of the medication.
It's so essential, right? It's that human connection.
It's so essential.
So,
and when it's missing, it can interfere with the medication working to the highest potential that it could work. It could even block a patient's perception, because pain is a perception.
pain is a perception. Pain is a perception. Tell me more about that.
So if you study the physiology of pain, it's the mechanistic pathway of pain, and there's 4 stages. I don't want to get too technical here, but the 3rd stage is perception, and then there's modulation. So you perceive, there's transmission, transduction, then you perceive. So let's say you cut your finger, and there's things that happen, and then there's things that happen in your nervous system. And then all of those chemical reactions and neurological things that happen tells your brain, okay, we need to figure out, what is this? Is it hot? Is it cold? Is it chilling? And then your brain says, okay, that's pain. We've had that before. Remember when you cut your finger last year? That's what that is. Move it. Hold it. It's bleeding. So it's a perception. And then another part of your brain might say, but you remember when you were in the hospital and you had that pain and they were nice to you? You better scream, because if you don't scream, nobody's going to believe you're in pain. Like if you stand there and laugh, they won't believe you're in pain. So then you scream. You go, oh, I'm in pain. Okay? So it's a perception, and your brain tells you what you need to do to get people's attention. You want your wife to know, hey, honey, I'm in pain. Come do something about this. And then as that perception comes back down, your nervous system starts to modulate, because now your body is saying, okay, where are we? Are we in an unsafe environment? Should we be running? Should we be sitting? And that's why when people in dangerous situations, maybe their arm is falling off and they need to get to safety, their body goes, okay, let's get this person to safety, and people can run for miles and not even feel pain, slow their bleeding down and everything. And then they get to safety and they just pass out, because the body is saying, we need to protect you until we can get you to where you're safe. And the brain is just amazing what it can do to protect us. So it's a perception. And the brain is very, very powerful to help you do what it needs to do in the moment, because it's also scanning the environment. It's watching people. It's watching what's going on. And it's assessing the clinician to say, is this person really believing me? And how should I act?
Interesting that you say, is this person really believing me? That idea of validation of one's pain. Am I on the right track with that?
Oh, absolutely. That's been documented in the literature, especially with people who have pain as a result. Let's say if someone had a injury to their back, especially with musculoskeletal pain, and maybe they're off on workman compensation, and they're having to go through some type of physical therapy or workman compensation program to get back to work. And it's been documented that people feel very distressed about being believed, and especially when they have lower back pain, because a lot of times they're long after the injury, when there's no signs of why they're having this intermittent escalating pain and resolution and pain and resolution, and they're going back and forth physical therapy. Maybe they're going to work and having to be off work and maybe having to have their work adjusted. They're constantly feeling like they're being judged, and whether or not their healthcare professionals, the people they work with, even believe that they're in pain, because they can have good days and then they can be flat on their back 2 weeks later for no apparent reason. And so this concept of being believed is very important, and it's very distressing.
I think back to my days of studying narrative medicine in New York, and of the case, there was a case where they had done a study on, I believe, soldiers who had been brought in injured from the battlefield. And these soldiers may have been missing a leg or a limb or gunshot wounds, etc. Definitely big injuries. And yet they found that these soldiers did not take as much narcotic to control their pain when they had the opportunity to talk about the injury that had landed them there in the field hospital or in whatever military version of the ED that there is. And the conclusion from that is, whenever we have time to frame our experiences and talk through those experiences, that can be as comforting for us as actually getting that shot of morphine or Dilaudid or whatever the case may be. It seems like there's some crossover here in what you're talking about too.
Well, when we start to frame treatments for pain and types of pain, so we have acute pain. So, and if you want to define pain, which I find it so difficult, because, acute pain is like right now. I come over there and I hit you in the head with a hammer. I'm hurting. You're hurting right now. Okay. We need to do something about that. Okay. You might want to take some Tylenol. You might want to take some kind of pain medication. You might want to say, Tara, please don't hit me in the head with the hammer. That'd be the best possible solution. Let's not get hit in the head with the hammer. But if you have acute pain, obviously, I'm not going to want someone to start talking to me about, let's talk about why you're in pain, okay? Let's be realistic. But when we get beyond the immediate moment or time that someone should be in pain, whether that is right now, a couple of hours, or out 2 to 3 weeks, subacute pain may extend even longer, from a few weeks to whatever is a reasonable amount of time for that episode. But I would say once you get to about 30 days, you're probably beyond acute and subacute pain. And now you have moved into what some would call persistent pain or chronic pain. Okay, and whether or not certain medications are going to be appropriate for that person would be dependent on a lot of different things. And you have a lot of different schools of thought. I think it is important for the person that is experiencing the discomfort to have a healthcare professional that their values and beliefs align. That's a big part of my theory. is the values and beliefs of the person in pain aligning with the healthcare professional. And then we begin to explore all of the treatments. I think we get stuck on what I call receptor treatments for pain. So treatments that focus on sitting on a receptor and blocking that receptor to eliminate the mechanism that's causing the pain. So you could have opioid receptor medication. You could have medication that maybe focus on GABA receptors, inflammation, so forth and so on. And they typically refer to that as multimodal. And then we can get into some cognitive behavioral therapies, physical therapy, but I'd like to go beyond that. I want to go beyond that and start to look at what I call comfort bundles, because typically that's as far as a lot of people get, because they start to say, well, when you start talking about massages and when you start talking about acupuncture, you start talking about Tai Chi and mindfulness, these things cost money. Well, everything costs money, and I mean, nothing's free. But some things weren't covered by insurance when they became mainstream. They became more available to people. And so we have to start to make things mainstream. We have to write, our congressmen. We have to write our legislators. We can't not put these things in front of people just because they may be cost prohibitive, but we can be creative in helping people to find ways of adding this to their toolkit so that they can start to use these things. And that was some of the work I did in my doctoral study. And I would help people find there's lots of 30-day memberships that you can get where people can try things for free. And then they can see if this works for them. And finding those 2 or 3 things that would go well with medication and things that they can do on their own. Little treatment things that they can do on their own. And sometimes when I recommend for people to have acupuncture and they can't continue with the acupuncture, maybe they only can afford 1 acupuncture treatment a month or 2 months, then maybe we can teach them some acupressure to go with that, and then some massage, and then some other things. So they have a bundle of treatments along with their medication to extend out all of the different things that they can do. So I try not to just get focused on just one treatment, but a combination of treatments. But most importantly, how can people self-care and self-manage?
So how do people self-care and self-manage? And to go back to what you said earlier, with the caregiver providing that comfort at the bedside, that intentional being present in the moment with the patient and validating what their pain is, or their issue, their sickness, their illness, their injury. How do we then move from that type of care into self-care?
So it starts by rethinking a model that is really illness care to a model that is actually health care. So most of the energy around pain management centers in hospitals, to tell you the absolute truth. Whereas 80% of people in pain is not in the hospital, and probably now with COVID, that's probably even a bigger number, because most people are avoiding going to the hospital. And I actually just did a video blog for my website that's titled, "What Happened to Pain?" Like 3 or 4 years ago, pain overdoses, the opioid crisis, the opioid epidemic. Headlines was everywhere. Like, you could go in the grocery store and pick up 3 magazines, and there would be some kind of article in there about pain management and people being overtreated or undertreated or not treated enough. And now it's just like crickets. Like, you don't even hear people talking about it. And people call me crying about how they went in the hospital and they got no information, or they had an outpatient surgery and they got little to no information about pain. Or they're calling me to say, I got 15 pills and now my doctor's calling me and saying I'm not getting any more, and I just had, my knee replaced. And so I think that we have to start to think about, how do we care for people in the community? And so how do we put people in the community and then connect people in the community from healthcare to get those services that they need? So that's how we go from the bedside to people's homes. We have to start thinking about a broader base, because all of this doesn't have to happen within a healthcare system. There are people in the community. It's a broader base of healthcare professionals that we maybe don't think of as healthcare professionals. And as an advanced practice nurse, I feel like that's part of my role, is to help people in the community understand who these health professionals are, what are their credentials, how do you know that they're licensed to do this work, whether they do energy work, or they're an acupuncturist or a massage therapist, or maybe they're just a health coach and they can help you seek out these people, or cognitive behavioral therapy, or even a physical therapist. You'll be surprised at the number of people with mobility issues that are sent home without a physical therapy consult. Yeah. Which is so important. I mean, mobility is so important when you go home, to be able to get around your home and not fall or not have an injury, or to be able to stay independent. Is so important. And if you're in pain and you're not moving, or you're having difficulty moving, you could fall, you could trip, you could get pneumonia, and that could land you back in the hospital again. So I think that that's how you go from the compassion caring person in the hospital to having this self-care and self-management. If people aren't staying in the hospital, well, before COVID was like 2.5 days, probably was the average length of stay. Now I think people are getting out of there as fast as they possibly can. We have to have this connectivity in the community. And that's what I hope to do with my private practice, is really to be able to offer people that extra service, to be able to figure out, what is my plan to manage my pain in the community, and who are the people in the community that I need to connect with.
What do you think is a common misconception by the greater public about those who go to a pain management specialist, or maybe even what their pain actually is? I would think that there's a great deal of misconception, just as you had already stated.
Well, I think the biggest misconception is that all pain management specialists are the same, and they're not. There's different ones, and they all serve a purpose. And I know that my number one thing when I start my practice is, I want all of my patients to have a primary care physician. Having a primary care physician, this is not a pain specialist, this is a generalist physician who is in charge of your overall health care. Someone that you go and see at least once or twice a year for your general health care. He's going to do your yearly physical, and everybody should be somewhere between January and March. You should be going to see your primary care physician or your primary care advanced practice nurse, and you should be getting your yearly physical. You should be getting your blood sugar checked, your blood pressure checked, getting all of your age-specific tests done, your colon screening, all of those different things. Everybody should have that person, because pain is a warning signal. And pain is good. That it tells you something's wrong and we should be checking on it. So this primary person is the first line of defense, going to your primary care doctor. So I don't want anybody that listening to this to think I'm against doctors, because I go see my primary care doctor January, February, or March. I'm in there getting checked up, making sure everything is okay. And then if around June, July, or August, if something's not right, I'm back in there again. So at least once or twice a year, you should be going to see your primary care physician. And then after that, if you need a referral, or if your insurance allows you to go directly to a specialist, then you have to decide, what do you need? If your pain requires, or you need an interventional pain specialist, they're going to be doing some type of procedure. But I think that there are things that can be done in some cases before you need an intervention. And I'll use myself as an example. I had some pain in my right knee last summer. I had been walking 2 or 3 miles, and last year I couldn't even walk a mile in a parade. I was in so much pain with my right knee, and I knew something was wrong. Now, I am a pain specialist, but I don't doctor on myself, because that is not good medicine. So I went to my primary care doctor. I followed my own advice, and I had picked up about 30 pounds after having a surgery. So I said, I know I need to lose some weight, but I want to go see an orthopedic doctor, and I want to get some x-rays, and I want to make sure that there's not something wrong that I need to fix. So I went to go see the orthopedic, and they took x-rays, and he says, yes, you have arthritis. So thank you for that information. I have arthritis. So we talked about all of the things that, he thought I could do, which was lose weight, and he wanted to put me on some anti-inflammatory medications, which is a common treatment. And he talked about an injection, and then we talked about what was next. And I said, well, I also want to go see a physical therapist. And we decided my treatments was going to be losing weight, going to see the physical therapist, and doing the anti-inflammatory medication. And when I went to go see the physical therapist, we did physical therapy on land and then in the water. So that was sort of like my comfort bundle. And that's what I've been working on. And to date, I've lost about 35 pounds. And I'm not doing the physical therapy anymore, but I am doing my own non-weight-bearing exercises and my stretches. And I do want to go back and get some more needling done. But these are all the things that I've been working on, and my pain in my knee is much better. I'm up to walking a mile now. I can walk a mile. And so it's a work in progress.
Well, first of all, congratulations, because anytime somebody follows the doctor's advice, I say congratulations. It's amazing how often people get some guidance from a doctor and it just never happens, right? Major props to you for taking on the hard tasks of getting yourself better. So thank you for that story too. You know my story, of course. You know the story of Jennifer, who held my hand and gave me that comfort in the emergency room the night that I was hauled in. And I always want to ask my guests to maybe share a story about a time that someone has been there for you, or that you have been there for someone else, and whether that's in your professional role or in your, which I'm sure you have many, many experiences of giving comfort in your professional role, or in your personal life. Are there any stories that that immediately spring to mind about presence?
Oh my God, there is probably so many. I don't know how much time we have. I guess that would be the factor in how long. But I, I think the one that I would tell would be in the ICU. But before I tell this story, I want to go back to talking about this pain specialist because I don't feel like I closed the loop on that because I was talking about the orthopedic. In that situation, I could have went to a pain specialist and got in steroid injections, but I didn't. And there's other pain specialists that do a myriad of other treatments. The goal is work with your primary care doctor like I did and come up with a plan that works for you. And make sure that the treatment is the treatment that's going to be the best for you. And so in my case, I chose self-care and self-management. Working with that physical therapist, getting my weight off. That's an example of self-care and self-management. Okay? Because I knew that there was some things that I could do before I just started chucking down a lot of pills, getting a bunch of injections, doing a bunch of treatments. And sometimes people get all of that and then they're still in pain, or they feel good for 2 weeks and then they're right back in pain. So what can you do to improve your sleep, improve your weight, decrease your stress, those type of things before you just start getting pills and getting medication? What's your part in all of this? That's the other part of self-care.
Yeah, we all have advocacy for ourselves, right? We should be practicing right. Self-advocacy, and sometimes doing the common sense thing is absolutely what we should be doing. Absolutely what we should be doing.
And your diet is really a big part. A big part of my diet now is eating lean and green meals. So I have 5 vegetables, green leafy vegetables a day. And I'm telling you to get those in. It's like, I don't feel like I don't have room for nothing else. I'm just like eating green stuff like all day long. Like I don't have time to eat nothing else. But they're anti-inflammatory. So that cuts down on me taking anti-inflammatory medication, which also can upset your stomach. So sometimes that's self-care and self-management. There are things you can do that doesn't require a pill, but it is a lot of work to try to figure out how to prepare these vegetables and eat them. And, they're not all the, hamburgers and French fries and all of that good stuff you want to eat, but they're a lot better for you. So this story, when I worked in the ICU, and I think this is when I really got to this therapeutic use of self as an intervention for pain management. The unit I worked on was a pulmonary ICU focused on the lungs. And at any given time, we really did not have the really sick ICU patient. We would have patients who were ventilator dependent, but they needed a lot of nursing care because they were ventilator dependent. And we had this one patient who had been on a ventilator for over 30 years as a result of a motor vehicle
30
accident.
30 years on a vent?
30 years.
Oh my goodness.
Mm-hmm. And his care was enormous. He had stage 3 bed sores down to his bones on both his hips, and stage 2 on his sacrum, so he had no turning surface. He had a trach in his throat, and he had a feeding tube. And he was in the hospital because he had infections, and they were trying to get these bed sores healed up enough where they could surgically close them. It was just a lot of care that he needed. And every time you went in the room, you were in there 45 minutes, and he was cold. So the room was like 90 degrees, and it literally smelled like meat was rotting. And so it was just enormous. And unfortunately, nobody really wanted to take care of him, including myself. And I came in one night, and it was my turn to take care of him. And that literally what happened is we would take turns taking care of him because his care was so enormous. And that night, when they assigned him to me, I prayed and I asked God to help me to not treat him that way, because I said, it's not his fault that he needs all this care. And I wanted to be a better nurse, and I wanted to learn how to take care of people who were on ventilators, because that particular time we had 10 patients who were ventilator dependent. So if we had 20 patients on the unit, odds are you were getting one. So what are you going to do? Not come to work? And I just didn't want to be that way. I wanted to be good. I wanted to be happy about taking care of these patients. And so I went in that night saying, I'm going to learn to have joy in taking care of these patients, and I'm going to figure this out. So anyway, I go in the room, and this nurse is giving me a report, and she's just like, I got to get out of here, And I'm just like, oh my God. So I go in the room, and I say, you know what? I am here to take care of you, and I have a wonderful plan, and I've got your meds all figured out, and we're going to get you so comfortable. You're going to sleep so well. And I'm Tara. I'm here to take care of you. And this is what I'm going to do. And I told him how I had his meds all figured out. And I said, and you don't have to ask me for anything. I said, I'm going to come in here. I'm going to have your meds. And I said, the only thing that I'm not just going to give you is your Norco. You're going to have to ask me for that. I said, but everything else, I said, your Xanax and your morphine, and he just had like 27,000 meds. I said, everything. I said, I'm going to be on it. And he was looking at me like, she's crazy. So anyway, and I was, because I was determined I was going to make him feel like he was the most loved and cared for patient. I was like, just Lord, forgive me for treating these people so bad, So I just was like in there, and I said, the only thing I ask is that when I come in, you let me get your nursing care done first. I said, because you have a lot of nursing care and I really need to get it done. And I said, but I promise you, every time I come in the room before I leave, I will spend time with you. And I will do whatever you want for at least 10 minutes before I go. I said, now the only time I won't is if my other patient light is on and I have to go. I said, but other than that, I promise you. I said, is that okay? And he shook his head. Yes. So I got busy, and every time I would spend time with him, and he was a quadriplegic, but he had upper hand movements, and he didn't want to word his mouth, which I was really good at reading lips, and that's what I wanted to do. He wanted to point to a letterboard, and that was driving me crazy because he was in contact precautions, and I was wrapped in his plastic, and I'm going through menopause, and sweat's dripping all down. I'm thinking to myself, oh my God, he wants to
take more time.
Point to this letterboard. But then I remembered this research that if you could figure out the first and last letter in a word, it doesn't matter if the letter's in the middle, because your brain reads words, not letters. So I would go first letter, last letter, first letter, last letter. And then I could figure, and he would just laugh, and I would be like, oh, that's what you want. And we made a game out of it. He would just have so much fun. And then we would talk, and I said, okay, now I got to go. But when I come back, we'll work on something else. And so the second night, I found out that his mother-in-law had died, and he was depressed. And so I got him put on an antidepressant, and we made him a card and had his wife, who was in the room all the time, but she was not interactive. She just kind of sat in the chair. And so I came with his meds and everything. And that night, by 11 o'clock, he was asleep. And so the morning he asked me, he said, he worded out, will you be back tomorrow? And I said, yes. He was like, will you be my nurse? And I'm thinking to myself, it's not my turn. And I said, yes, I'll be your nurse. So the next night I had him again, and we went through the whole rigmarole, and we were having fun again and laughing. And then he said the same thing the next day. You back tomorrow? And I'm like, I'm on a 4-day stretch. He's like, yes, I'll be your nurse. And so the next night I came in, he was gone. He got better, and he had went to the step down unit. And I'm halfway through my shift, and I hear his wife flopping through the unit. It's Tara here. It's Tara here. And I stick my head out like, oh my God, he's coming back. And I said, yes, I'm here. And she was like, my husband had me write this for you. And he had wrote, I am so sorry I left you, but I got better. And you're the best nurse that I've had in 30 years. Would you please come up to this unit and teach these nurses how to take care of me?
Wow.
And when I looked back at his meds, he was refusing. He never asked me for the Norco, which the nurses claim he was begging for. And the only thing I did was I gave him Tylenol and I gave him the Motrin around the clock. I just gave it to him because it was PRN. So every time it was due, I just went in and gave it to him. And I never made him ask for any of his meds. I was there 10 minutes before they was due. I was in the room with him. I got your meds. I'm giving you this, and this. You need anything else? No, because I had it all there. And what I tried to do was preserve his dignity as a human being and preserve his dignity as a man. And I tried to imagine myself lying there and not even being able to scratch my nose if that's what I wanted to do. Like if he wanted to scratch his nose, I would have to figure that out and then figure out how to scratch his nose. If his eyes was itching, and quadriplegics, their eyes dry up a lot. And I learned to fold a little 4x4 and just put it over their lids and rub it so I could scratch their eyes. To me, this is all a part of pain management. This is all a part of comfort. These are all the things that provided him with comfort, which caused him to not need pain medication.
That is such a beautiful story. And there's two things I really want to highlight. Number one, thank you for your authenticity and vulnerability of saying, I didn't really want to take care of this patient. I've been that patient that nurses didn't want to take care of either. Not because, probably because of the amount of care, but also because of the attitude, because of the mouth that can sometimes go along with patients who are hurting. But I have to tell you, I'm so touched by what you prayed, that you didn't pray, don't make me have to take care of this patient, but help me learn how to best take care of this patient. And what a tribute to changing oneself instead of changing the situation. I'm going to take a lot from that. Thank you.
Yeah. And then I just went crazy with it. I started taking care of all the quadriplegics, and I would put long lists on their everything, how they like to lay, everything they like to, and I would just go whack on everybody. Would go, oh, Tara had this patient. Look at all this stuff, and I would just put these long lists because, to me, it was an honor. It was a sacred duty to be able to advocate for them and to provide for them what they could not do for themselves.
This is sacred work, right? This is sacred work.
It is sacred.
I often say this is not manufacturing, right? This is not retail. This is not industry. This is human beings taking care of human beings. And wow, I cannot thank you enough for your care of that patient and for your continual learning and development and research that ultimately will help so many other patients like me and like this gentleman that you've described here too. Thank you.
And I think that is what these stories is what led me to write my theory. It was called the Nichols Nelson model of comfort. I renamed it the therapeutic model of comfort, because this clinician-patient relationship, it is key. It is classic, and therapeutic skills are not taught in healthcare, and they are the foundation. Therapeutic competencies. We are now starting to see people talk about motivational interviewing. That is a step, but to me, that is just, it's like the iceberg. There is so much more to therapeutic competencies, because you really have to look in yourself. It's not about me getting the patient to do or act the way I want them to act. It's really about me looking in myself and saying, I'm the professional, and I'm here to support this person. And I have to leave my biases at the door. I have to leave those at the door. And I have to show up, because this person is literally depending on me. And I had no idea that I was impacting this person the way that I did. And he was just, he said he slept. And I mean, it was great that he thought I was the best nurse that he had had in 30 years. But he said he had slept for the first time. Yeah. I mean, that was huge.
Yeah. Those, I don't know if that's necessarily a clinical outcome, but I assume it is when you're getting better rest.
Yeah, I mean, he said he slept both nights. And I knew, like, by 11 o'clock, everybody was looking like, that patient hasn't put his call light on. I said, because he's asleep. Leave him alone. And they was like, how did you do that? I was like, listen, he's asleep. I met his needs, and now he's asleep. Just leave him alone. And they was like, you always do that. You always come in here and take the worst patient, and then they're all good for you. I said, well, don't worry about it. Just don't worry about what I'm doing. Leave my patients alone.
Oh, wow. This is...
Maybe y'all can learn something from me.
I think we can learn a lot from you. I've learned a lot from you just in this hour. So, hey, in the time we have left, can I shoot a couple of rapid fire questions past you that really don't have anything to do with healthcare or nursing or pain or anything like that?
Sure, go
so my first question is, let's say you were stranded on a proverbial desert island. And yet on this desert island, you can keep one piece of art with you. One piece of art, whether that's a film, a book, a visual piece of art, sculpture, theater. What would the piece of art that you would most want to have with you?
Well, that would be easy, because it would be this collage that I made with my grandbaby, Junior, and we made this finger painting. And it's got all these pretty colors, and he was just like, and I was trying to make it pretty. And I actually have it framed, and it's beautiful, and it's downstairs in my bedroom.
That's
and
awesome. How old is he now?
2. Oh, he's 2, going on 35.
2 going on 35.
He's ruling the world, honey.
That is awesome. That is awesome. So my second question for you then would be, if you could live for one day, live the life of any fictional character, what character would you choose and why?
Fiction? Fictional.
Spider-Man?
Spider-Man.
Okay. You're a woman after the heart of my wife. So she also loves Spider-Man. That's fantastic.
Yes.
And so the last question I have for you then is, if you opened up your pocketbook, your wallet, your PayPal app, and you found that $100 had magically appeared in your wallet or your phone, what is the first thing you would spend that $100 on?
Wow, $100. Wow. I don't know. I probably go
Yeah,
get my
yeah,
nails done.
that's a good one. That's a good one.
Yeah, probably just go get my nails done. It's not a lot you could do with a
You
hundred
get your nails
dollars.
done. Maybe a cup of coffee while you're
Yeah,
at it.
I could. Yeah, maybe a cup of coffee, but I definitely would go get my nails done.
Might need it too right now.
Yeah, yeah. It's winter time. They're all
Well,
beat
Dr.
up.
Nichols, thank you so much for taking the time to be on the podcast. Thank you for all of your work and all of your advocacy for patients who are hurting. It's been an honor for me
Hmm.
to talk to you, and I cannot thank you enough for being with me tonight.
Well, thank you for having me. Like I said, when I met you, you're a rock star, and you made my world when I
To
met you.
know that I had any influence on helping you get more knowledge and more expertise in this idea of pain, I take that as a huge compliment. Thank you. And so, thank
Hmm.
you all for joining us for this episode of Compassion and Courage Conversations in Healthcare. I am your host, Marcus Engel, and this is the podcast where I teach compassionate communication, provide perspective, and inspire resilience. Thank you all so much for being with us, and we will see you on the next episode.